High on praise and exaltation. We are Hope 103.1 FM.
You didn't come for the strong, you're here for the broken. This is my song of intercession, God. Only you know, only you know how it feels inside. This pain when you try to hide it, afraid to cry for help. You smile and drown it out. Only you know how it feels inside. To try and try and try and try and try and fail. Oh. Only you know why you say the clock and he's not home. Out with his boys drinking, cause he knows when he goes home and opens that door, it's another night of fighting or silence. Oh, she's cutting up deep, and they just think that she's crazy, but you know better not. You know she's being touched in the wrong way. Oh, doctor, can you heal him? I pray, cause if you don't, he will not make it. Doctor, can you heal her? I pray, cause if you don't, she won't make it till the morning. Doctor, can you heal them? I pray, cause if you don't, they will not make it. Doctor, can you heal them? Cause if you don't, they won't see the morning. Oh, 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 oh. Only you know how she feels inside. These feelings she's trying to hide, that's for another girl. It's not supposed to be. Only you know she prayed and prayed, how much she is afraid to get the help she needs, that your blood can set her free. Oh, only you know she's going to church but losing hope, cause he's tired of repenting for the same things over and over. It's almost over for him. Only you know I'm surrounded by broken people, and they need a hero cause they can't fix what's wrong on the inside. Boys here in the city, doctor, can you heal her? I pray, cause if you don't, she's not gonna make it. Doctor, can you heal her? I pray, yeah, cause if you don't come, no, doctor, can you heal them?
Hi, a pleasant good evening to one and all. I would just like to say welcome back. Welcome to all our viewers, and you are listening to Heavenly Medicine. I am your host, Dr. Xenia Louison, and it is a pleasure to join you back once again as we speak on a very exciting topic today. Okay, along with this topic, we also have a doctor joining with us today. She is no longer a stranger, but she is Dr. Janelle Harford. Again, we would just like to welcome her. Dr. Harford, it's a pleasure having you with us this evening on Heavenly Medicine as we venture into the topic of endometriosis and women's health.
Thanks for having me.
Okay. All right, guys. So again, we'd like to just welcome you. Those of you that are viewing on YouTube, on the platform of YouTube, those of you that are viewing on Facebook, or those of you that are just listening on your vehicles as you're on your way home from a busy work day, we just want to say thank you for listening in. Thank you for joining us as we share or get into this topic of endometriosis. We have many women that are excited and ready to listen in on this topic as Dr. Harford is going to get us into it as to what endometriosis is, what are some of the causes, its symptoms, signs, and how it can be treated. Okay, so we just want to say sit back, relax, and enjoy the show on Heavenly Medicine as we take you into this journey of endometriosis and how we can treat this problem. Okay, so Dr. Harford, again, welcome this evening. Thank you for joining us. It is a pleasure having you.
Absolutely. I'm happy to be here educating our people.
All right. Okay. So I think we can just get in. I just want to just say hello to Sylvina Charles. Good evening. Good evening to you, Natalie Hazard. Good evening. Thank you for joining us, guys. We're also welcoming everyone. You can message us, you can WhatsApp us on the number 403-1031. There you can send in your questions, your comments. Those of you, if there's any testimonials that you would like to share on this topic due to your own personal experience, please, guys, feel free. You can call in. You can share your testimonies, whether you want to send it either through the platform YouTube or Facebook. We're here. We would love to have you. We would love to hear from you. As we're learning from each other, we're also sending this information out to the public. We want to sensitize the public, especially pertaining to women's health and some of the diseases and some of the things that affect women. So this is exactly, we're so grateful to have Dr. Harford here with us because it's a cause that we know that many women shy away from, but we would like them to know that you are not alone and we are here. We are here to educate you. We are here to guide you and to help you along your journey to good health. Okay, so Dr. Harford, we'd just like to get into it. So, can you tell our viewers exactly what is endometriosis? Because I know it can be a mystery for many.
Okay. So before I even dive into the definition, we would kind of have to picture the uterus and the
Okay.
different layers that make up the uterus. So when we're speaking specifically about endometriosis, we are talking about the innermost lining of the uterine cavity. And there are specific cells that are on there, including the glands and stroma, that's the terms. And whenever these glands and stroma appear outside of the uterine cavity, that is what endometriosis is. Now, typically, it's very common in the pelvis, but keep in mind it can be elsewhere in your body, which we'll go into more, I guess, when we get to the symptoms. But it's the cells that are usually lining the cavity of the uterus that has now moved elsewhere outside of the uterine cavity.
Okay, so as we are trying to visualize this and for our viewers to visualize it, so we have our uterus, and there we would have, okay, as we are illustrating on the diagram on our screen. So can you just take us through this diagram as to the organs and what we're really seeing here?
Okay. So this is an image of the pelvic organs, and it includes right at the center is the uterine cavity. Off to the sides at the top, you have the fallopian tubes, one on either side. And just beneath that, that little white ball on that picture represents your ovaries, and you have one on either side.
Okay.
So if you take a closer look at this picture, right in the middle of that cavity, there's two colors. There's a pinker color and there's a lighter color right in the center. That's actually your endometrial lining. So the cells that are typically there lining the cavity, when they have moved outside of the cavity, it becomes endometriosis. And they're considered ectopic, presentations of where that glands and stroma will be.
Okay.
Also in this picture, you can see little, well, this one has red colors at different places. That's showing you some of the places where these cells can be located. The most common of them being the ovaries, but it can also be anywhere in the pelvis, including you see next to the cervix. It can be on the fallopian tube. It can also be on your bowel and even in your chest cavity, which is not a very common presentation, but believe it or not, it can happen.
Okay. Okay. So, Dr. Harford, so is there any other locations that you can actually see these endometrial cells located, seen as they're ectopic, or any examples from your practice that you had the experience of seeing? Can you share that with us?
Absolutely. So back in residency, actually, I was a surgical resident, not even in my field as yet. We actually encountered a patient who had ectopic endometrial cells on her abdominal wall.
Wow.
And I'll just break this down in simple terms. She had previous surgery,
Mhm.
And on that incision, she presented with bleeding every month. Around the time when she would have her cycle, she would actually bleed from her skin where the incision was. And that is also included in this picture of endometriosis. It can be found on your abdominal wall. It can be there after having surgery. Because remember, these cells are not something you can identify with your naked eye.
Okay.
And in doing surgery, they may get implanted into that scar and stay there and present with the symptoms of pain and sometimes even bleeding from the incision.
Wow. Okay. So, all right. So we just mentioned the incisional scar. Is there any other place that you can also find it that is just completely outside of the reproductive organ as well?
Absolutely, yes. On your bowel, it can be present on your bowel, and just keep in mind, pictures probably don't really show exactly, where they're located, but all of this is in contact with your uterus, your pelvic organs, your bladder, as well as your bowel. So those are two other areas you can find it. And whenever it's in these areas, it may present with different symptoms. So, for instance, if it's implanted on your bladder, patients may have urinary symptoms. If it's
Mhm.
on your bowel, patients may present with either diarrhea or constipation, and
Okay.
sometimes just a general crampy feeling in their abdomen. Another place that's not very common, but it can happen, is in your chest cavity. So
Mhm.
patients, the same way you have periods every month, they may have symptoms every month related to chest pain, difficulty breathing. They even may cough blood as well.
Mm.
That has happened before. And it can all be related to endometriosis, which is when the cells that are normally in the cavity of your uterus has now gone elsewhere outside of your uterus.
Wow. Very interesting. So, in terms
Mhm.
of endometriosis, is there any as a percentage or so as to how often we would see cases of endometriosis among women of childbearing age?
So it occurs in about 10% of the reproductive age women. In particular, the age range is about 25 to 35. Keep in mind, though, it is something that can go undiagnosed
Okay.
because it presents with very vague symptoms for a lot of patients, and there is really no blood tests or specific lab work that you can do to tell a patient, yes, you have endometriosis. It's definitively it's diagnosed through surgical procedures, but based on a patient's clinical presentation, you can have a presumptive or a non-surgical diagnosis as well. But it is something that can be undiagnosed for a very long time because, I mean, if you have abdominal pain or just pain during intercourse, patients may not typically think, oh, well, I have endometriosis or seek
Right.
help for that.
Hmm. Hmm. Okay. So, what are some of the, I guess, the general symptoms, signs and symptoms that a patient will experience with endometriosis?
So there's several symptoms a patient can experience depending on where these lesions are. But in particular, the top three, and
Hmm.
one of the most common I would say is pelvic pain. So 80% of patients with endometriosis will present with pelvic pain. The other thing is a major, major, major topic and has affected so many lives is infertility.
Right.
25% of patients with endometriosis present with infertility, problems having a child, whether not being able to get pregnant, multiple miscarriages, or even ectopic pregnancies. And again, the word ectopic comes in play. So,
Yes.
ectopic essentially means outside of where it should normally be, to
Yes.
keep it simple. So, an ectopic pregnancy in relation to endometriosis is where that pregnancy may get stuck in the tubes or even on the ovary, but not in the right place where it should be, which is the uterine
Okay.
cavity. So, those are the top two. And the third one, ovarian masses as well. So, endometriosis, like I mentioned before, can occur on the ovary.
Yes.
When that happens, remember your lining of your uterus causes bleeding. Now,
Right.
on the uterus, those cells will cause bleeding and a collection of blood can form, leading to what we call a chocolate cyst or an
Okay.
endometrioma.
I
And essentially, if you would cut that open, it's just thick, brownish chocolate material, and that's where that term came from, which is a chocolate cyst.
that's
So those
correct.
are the top three. But like
Okay.
I mentioned before, it all depends on where you have these lesions.
Hmm.
So patients who have very severe endometriosis with nodules, a little, seated implants in the back of the uterus, they would present with pain during intercourse. with
Okay.
penetration. They have a lot of pain with intercourse. Other patients who may have it on their bowel, like I mentioned before, will
Yes.
have diarrhea, constipation, abdominal cramping. People, if they have it on their bladder, will have problems with urination as well. And if it's in their cavity of their chest, will have difficulty breathing, chest pain.
Wow.
Sometimes even collections of blood can form between the layers of your the lung, the outer layers of your lung, and they can cough up blood as well too. So it's an array of symptoms. One thing I forgot to mention, which is very common,
Mhm.
painful cycles.
Okay.
They have a lot of pain during their periods. This pain can occur sometimes even 2 to 3 days before their cycle starts,
Hmm.
continue throughout their cycle, and as well as a few days after. Heavy bleeding or heavy periods is also
Yes.
something that can go along with endometriosis.
Mhm.
And the term that we use is menorrhagia, meaning bleeding for more than 7 days at a time for your cycle. So, in a nutshell, those are some of the most common symptoms that a patient may present with.
Wonderful. Okay. And basically we have many patients that would say to you, how do I know that I either have endometriosis or a fibroid? What makes it different from being diagnosed with fibroids to being
Mhm.
told that you're diagnosed with endometriosis?
Okay. So, clinically, these conditions go hand in hand because, as you can see, they have very similar presentation. Because fibroids will also give you pelvic pain, they would
Yeah.
also give you heavy periods,
Yes.
also have a problem with miscarriages as well or getting pregnant. So they overlap in terms of their symptoms. However, in terms of a fibroid, an ultrasound will be quite easy to detect whether you have a fibroid or not. In
Yes.
terms of endometriosis,
Hmm.
unless you have that endometrioma or that cyst on the ovary, or big nodules in the back of the uterus, you really don't see anything that could tell you for sure you have endometriosis just by looking at imaging. So
Okay.
that's one way that it can be different. Of
Definitely.
course, with fibroids, you have other symptoms that can be related to the size of the fibroid, so space, occupancy in the
Hmm.
pelvis, where endometriosis may not really have that impact, but they're quite very similar. So unless you have imaging done or some definitive diagnostic study done, you can have very similar symptoms and be misdiagnosed.
Okay. So is there any way that patients can also have both conditions, both endometriosis
Absolutely.
and fibroids?
Absolutely, yes, absolutely. Because keep in mind, with fibroids, you are at higher risk for having heavy periods to begin with.
Mhm.
And that in itself is a risk factor for endometriosis. The heavier your cycles are, and I'm sure we're going to get into the causes of
Definitely.
it, which will make more sense.
Yes.
The heavier your cycles are, the higher your risk of having endometriosis.
Wow. Okay, wonderful. So I think we can definitely get into some of the risk. Okay, so I know some of the ladies will be wondering, okay, well, what can be the risk factors for these? What are some of the risk factors? Am I at risk? What are some of the risks, Dr. Harford, that can definitely put you in the category of having endometriosis?
Okay. So heavy periods, definitely one of the risk factors.
Hmm.
Also, keep in mind this is a condition that is dependent on hormones, in
Okay,
particular estrogen.
correct.
So, conditions that would pretty much have a woman be exposed to estrogen longer in her lifetime will increase your risk. And some of these include nulliparity, meaning she has no children.
Okay.
So,
Mhm.
if you don't have any children, your body is exposed to estrogen for a longer period. So, that
So
does
meaning
increase
more
your risk.
cycles, you're having actually more cycles than having a break
Exactly.
time to actually have a fetus and to go on for a
Exactly.
period of 9 months.
Exactly.
Okay.
So,
Hmm.
yes. So, less children or no children, that will give you a higher exposure of estrogen.
Okay.
Also, if you started periods earlier, and earlier meaning around the age 11 to 13,
Okay.
or a late menopause as well. So, these meaning, like you just said, you have more cycles, so more exposure to estrogen. So,
Okay.
those are conditions that can increase your risk.
Yeah.
Also, patients who have uterine anomalies. These meaning their outflow tract, because
Mhm.
remember you bleed and that blood is supposed to drain out naturally. If
Right.
that opening is not normal, meaning you have an imperforated hymen, and hymen usually is a ring, but if there's a part of tissue that's completely blocking that vaginal outflow, then that blood kind of sits in the cavity, it cannot come out, and that increases your risk of endometriosis. We also have race playing a factor in your risk for endometriosis. In particular, white or Caucasian women have a higher risk of endometriosis in
Mm-hmm.
comparison to Black women or Hispanic women.
Okay.
I
All
hope I'm
right.
not leaving out anything.
All right. Okay. All right. So in the case we just mentioned, right? So some we just looked at the difference between the fibroids and we looked at between fibroids and endometriosis. So can you tell us a little bit more that there's also a condition that is somewhat associated with endometriosis, but it's not, right? So can you give us a little bit more as pertaining to adenomyosis and what is the difference from endometriosis compared to adenomyosis?
Okay. So, endometriosis involves the stroma and the glands of the lining of your cavity going outside of the uterus.
Yeah.
With adenomyosis, it's very similar, but this situation, the cells actually go into the wall of your uterus, into the myometrium. Now, it does present with similar symptoms. Patients have lots of pain with their cycles, called dysmenorrhea. The uterus, we describe it as being a very hard or a woody uterus. When you examine the patient, the entire uterus is very firm and hard. On
Okay.
an imaging now, in terms of ultrasound, and I'm glad you put that picture up. Just look at that left picture. You see those little red spots all through the uterus?
Mm-hmm.
On an ultrasound image, you would actually see like cystic areas throughout the wall of the uterus. And that is what endometriosis is. So they are quite similar. The only difference is with adenomyosis, it actually involves the uterus, but the myometrium or the muscle layer of the uterus. With
Okay.
endometriosis, it can go beyond that to different organs outside of the uterus.
And it's the same way when you have the period, it would bleed the same way as when it's in adenomyosis.
Very similar, correct. So they have heavy periods, sometimes prolonged cycles, and very painful cycles as well.
Mm-hmm. Mm-hmm. Something I was actually going to add, you mentioned in terms of the risk factors, but I think one of them, I remember we discussing it earlier, it would have been family history,
Oh,
right?
yes,
Yeah.
absolutely. Yes. Family
Yeah.
history. So,
Yes.
and I really tend to see this a lot in my practice where patients actually they will bring their younger adolescents, their children in,
Yeah.
and saying, she has very similar symptoms to what I've had when I was her age, like 15,
Mhm.
16, young
Mhm.
teenager. And yes, 7 to 10 times more likely to have endometriosis if your family members have it as well.
Okay.
Your mother, your sister, your grandmother, aunts, 7 to 10 times more likely if it's in your
Okay.
family.
Okay, so in terms of that, how does it impact? Does it impact greatly on infertility, on your fertility as a woman?
Yes, it does.
Hmm.
Yes, it does. And for different reasons. Now, with endometriosis, because these cells get implanted elsewhere,
Yeah.
including the ovary, having that large cyst or endometrioma on the ovary, that can also decrease fertility. So, for instance, patients who are diagnosed with that, it actually is recommended that the cyst be removed to improve their chances of fertility. Now, also on your tubes,
Hmm.
if there's any implantation of these glands or stroma on your tubes, it can cause scarring. Now,
Okay.
scarring can lead to blockage of the tube, and that can increase your risk of ovarian cancer, sorry, of ectopic pregnancy. So
Okay.
that in itself can cause, and that's a good picture. With that, you see the adhesions from the ovary to the tube and from the
Yes.
ovary to the uterus. You can
Yes.
see that there,
Mhm.
and it causes scarring and increased risk of ectopic pregnancy.
Mm.
Patients with endometriosis also have a higher risk of miscarriages as well. So those are the three main things, that can definitely affect the woman's fertility. And also, I'm, just gonna put that out there. Imagine a person with severe endometriosis. She is not um, comfortable during sexual intercourse as well.
Yes.
So if that libido or that sexual drive or desire decreases, that in itself will decrease her chances of having a child or becoming pregnant.
Definitely. Okay. Well said. That makes a lot of sense, does it? All right. So we looked at the different risk factors. What are some of is there specific etiology behind endometriosis or is what are some of the theories behind endometriosis?
Right. So it's theories. And I'm glad you said that because there really isn't anything we can pinpoint in particular. Because endometriosis, yes, it affects reproductive women, the most commonly. However, it can affect pre-menarchal girls as well as postmenopausal women as well. So these theories are what we can come up with so far that can explain, what's going on. But neither one fits all categories of women. But the most common is called Samson's theory.
Mhm.
And what that is essentially is a backflow or retrograde flow of your cycle. So
Okay.
whenever you have a period, you're expected that that blood flows out naturally from that cavity, the uterine cavity, out through the vagina.
Mhm.
However, in endometriosis, some of that blood can back up into the tubes, and in so doing, the cells get implanted outside of the uterus and cause endometriosis.
Okay.
Okay, now that's the most common. It does not explain all of it. So they have proposed that it also is some changes with your immunity or inflammatory cycles. It also can be spread through the vasculature, through vessels, as well as your lymph system as
Mhm.
well, or even the coalomic metaplasia. That means when the cells that are on the bowel and so can change. So
Okay.
those are some of the proposed theories. In pre-menarchal, meaning young girls who have not started their cycles yet, but who
Yeah.
are experiencing symptoms of endometriosis or may have it, they assume that it's due to the hormones that they have been exposed to when their mom was pregnant. So maternal
Okay.
hormonal effects.
Mm. Okay. All right. Would DES be one of those toxins
Yes.
also?
Yes,
Okay.
so DES is a drug that we obviously don't use that anymore because
Anymore.
there's a lot
That's
of
correct.
risk factors for cancer, uterine cancer, endometrial
Mhm.
cancer, and endometriosis now.
Mhm.
But it was a drug that had been given to women many, many years ago. And when they are pregnant, if they were exposed to it, the fetus that they were carrying was at risk when they were born for these conditions.
Mhm. Yes. Thank God they're no longer on the market.
Yes.
So hopefully the presentation with endometriosis would be of some different cause.
Yes.
So today, what we want to look at is in the event, okay, now that we know about it, we know some of its cause, the etiology. Now, how are we about to treat this?
Okay. So keep in mind, it is an estrogen dependent condition, meaning the more estrogen you have in your body, the higher the risk of having endometriosis, as well as the severity of endometriosis.
Hmm.
So, if we have medications we can use to kind of shut down the production of estrogen in our bodies, it will
Okay.
help.
Hmm.
Okay. Now, the first line treatment, we can try anti inflammatory medication. Like I mentioned before, there is an inflammatory response
Hmm.
that is related to endometriosis that causes this patient to have pelvic pain.
Yes.
So if we can, help that or curb that, it would help their symptoms. So some of those are non-steroidal anti-inflammatory medication. And on simple terms, we know these are very commonly used: ibuprofen or Motrin,
Hmm.
Aleve, Advil, any one of those, naproxen. So
Okay.
that's the class of drugs that are used for that. Now, if that does not work, the next step that we do
Just
is we're
that.
gonna combined oral contraceptive pills.
Okay.
So birth control pills are not just used for, preventing pregnancy. There are many, many, many other indications for their use, and one of them is endometriosis. So what the oral contraceptive pill does, it pretty much takes over the function of the ovary or stops the ovary from producing estrogen. So if
Okay.
you can cut off that, then the endometriosis lesion should not become worse.
Mm.
Whenever you take oral contraceptive pills, your cycle actually changes as well. So it's expected that you have less bleeding and for less number of days.
Mhm.
Remember, one of the risk factors was heavier cycles. So if you can decrease that, then you would help prevent or improve this patient's symptoms from endometriosis. So those are the first two. Now, if none of that works, we do have other drugs on the market that are available that they're, I want to keep it very simple. I'll say what the term means medically. They're GnRH agonists. And in
Okay.
simple terms, what that means, you get these compounds in the medication.
Yes.
It acts on a part of your brain. That part of the brain is called the pituitary.
Mm-hmm.
The pituitary actually secretes a special hormone which is GnRH, and that hormone stimulates your ovaries to produce other hormones that eventually leads to estrogen in your body. So
Okay.
when you get that GnRH agonist, it takes up space where these receptors are, and essentially it decreases two hormones from your ovary, which are LH and FSH. That's for follicle stimulation and ovulation. So it decreases that, and then when those drop, it decreases your estrogen levels, and that's how it helps.
Okay.
One of the examples is Lupron. I'm not sure what brand name you have on the market in
Yeah,
Grenada.
we have Lupron here, and yeah.
Okay.
Mm-hmm.
So one of them is Lupron. It's recommended for about a 6 month therapy.
Mm-hmm.
And it can be extended for another 6 months, but it's not something that is used long term
Okay.
because one of the major side effects is negative effects on your bone health. It
Okay.
increases bone loss. So we really
Yes.
don't want to use that for a long, long period of time. So that's one. Actually, now, so that's a shot, right? It's given as a shot. We actually have a pill that we use now as well, which works very similarly. It's called Orilissa, Orilissa. It's used in a similar way, but it's in the pill form, and it works very similarly to help decrease the estrogen production from the ovary.
Mm-hmm.
And like I said before, these are not long-term use.
Mm-hmm.
It's only used for a 6 to 1 year period just because of the negative effects on bone health.
So just to cut you a bit, so the Orilissa, it is not a GnRH agonist. It's what did you just mention instead it was, so that our viewers can what did you say it
Oh,
was?
okay, it's similar. It's a pill form and it helps to shut down, yes. So it's one of them was a shot, which is an injection, and the other one's a pill form.
Okay. So
Mhm.
in the case of the GnRH agonist, does that put you in some type of menopausal state? Yeah.
Yes, it does. Yes, it does. So some of the side effects patients may experience, one, they may not have a cycle at all. So amenorrhea is something that can happen. The
Okay.
other thing is they may have menopausal symptoms, which are vasomotor symptoms, hot flashes, night sweats.
Mhm.
They may become irritable as well. So similar menopause symptoms, yes. Because remember, you're essentially putting your body into hypoestrogenic state, meaning
Yes.
less estrogen or no estrogen at all. And that's what happens when a patient goes through menopause. So yes, you do have menopause symptoms
Yes.
as side
And
effects.
in order to counteract those side effects, then you would
Mhm.
still give them the oral contraceptives, right?
Correct.
Yeah.
So that's called the add-back therapy. So to help with those symptoms, a patient can be on birth control, which contains the two hormones from the ovary. You can either use one, progesterone only options,
Okay.
or you can use two hormones, which is estrogen and progesterone, and these all come from the ovary naturally. So you can use those as the oral contraceptive pill along with those medications to help prevent the menopause symptoms.
Okay, wow. Okay, but is there some type of at the end of the treatment where the endometriosis now has lessened, the cycles now has after a period of 6 months, can these patients still be able to recover back a normal cycle somewhat?
They can, yes. Usually within 60 to 90 days, a cycle will typically return. Yes.
Okay. Okay,
Mhm.
and chances are their flow would just it would be regulated
Yeah.
somewhat.
Right.
Okay.
So with endometriosis, with these drugs, it helps to shrink the lesions and, of course, help their symptoms.
Yeah.
However, there is a risk of recurrence of
Yes.
endometriosis, meaning it can
Mhm.
always come back if you're not on medication. And the average is about 20% may come back within 2 years, and
Mhm.
about 40 to 50% of those patients may experience symptoms again within 5 years.
Okay.
Yeah.
Is there anything besides the medication that can also be used?
Right. So, in the event that you've tried all medical options and the patient is still having severe symptoms,
Yeah.
then we would talk about surgical options. And these include most times it's done with laparoscopy. I'm not sure if that's available in Grenada right now.
Not by
But
way.
it's minimally invasive, meaning the patient will recover faster. But
Okay.
essentially, it's going into the abdomen and actually identifying those lesions,
Mhm.
and we call them ablation, or I would keep it in simple terms, we burn them off or remove
Right.
them.
Yeah.
Yes.
Hmm. Okay.
Mhm.
All right. Okay. So I think we pretty much would have went through most of the um basic treatments for endometriosis. But some of the questions I know that some of our women really do have is in terms of the infertility. So some of them, is there anything that they're asking? Is there anything that can enhance the or improve fertility even though you have endometriosis?
So for a patient with endometriosis, you would of course have to go through that period of time where you have to try naturally. And once you get to that 1 year mark, which is 12 months of actively trying to become pregnant and you're not successful, then we move into an infertility aspect. And of course, the drugs that we have been using, one of the most commonly used is Clomid, and that
Mhm.
helps to induce ovulation. So therefore, it increases your chances of becoming pregnant.
Okay, all right. Doctor, we just have a few comments or so from other persons. Let me just we have from Miss Claudia Mack. She's just saying quite interesting and relevant topic. We have a question though from a viewer on YouTube. She's asking, what about functional medication? So I'm not sure about the term functional medication. I don't know if you've
I'm
heard
not
of
sure what she's
it.
alluding to
Yeah,
either.
I'm not too sure. Maybe she can just add a little bit more and let us know exactly what is she referring to.
Mhm.
Okay. Then we have another person here that is basically she's sharing her experience, and she's basically saying, I have been diagnosed with pulmonary endometriosis, as you just mentioned,
Mhm.
which is very rare. And she said it
Mhm.
is a rough road to pass. So in a
Yeah.
case where a patient would also be experiencing that pulmonary symptoms, pretty much there it's pretty hard in terms of going where it's in the pulmonary, it's in the lungs. All
Right.
right. So it's
So it
really
depends on the severity. I have not encountered management, you know, as a personal level with a patient for that. But
yes,
just from experience in terms of like lung cancer,
yes.
endometriosis, like I mentioned before, if there's any bleeding, it can collect in the pleural space between the lining of the lung and the chest wall. There's
Okay.
a cavity there, the pleural cavity. And
Hmm.
they have used in the past for patients with cancer where you collect fluid in that area. They use like, I don't know if you came across like the talc powder,
Hmm.
where they create an inflammatory response within the two layers and it causes it to stick. So there's
Oh,
no space there anymore, no potential space there to, for bleeding to occur. But
hmm.
a case like that would be way outside of my capacity as an
Because
OBGYN,
now we're
and
dealing
it
with
will have to be referred to a thoracic surgeon, and they will probably have to go in and remove those lesions and also consider closing that pleural space.
wow. I would just
And of
love to
course,
hear what she would share. I would love to know what exactly how her treatment regimen has
yes,
been.
yes,
Yeah.
and of course the hormonal options, which we spoke about before, the
Mhm.
combined oral contraceptive pills will help because the tissue will respond to the medication no matter where it is.
That's correct. Yes. Hmm.
Yes.
Hmm. All right, that's a good one. All right, so I think so far, we definitely, viewers, you can send in your questions. Feel free to call in if you have any testimonials. Again, our number is 403-1031. You're listening to Heavenly Medicine, and today we have joining us Dr. Janelle Hafford, and our topic is endometriosis. So, ladies, please feel free to call in, ask your questions. You can even send your testimonials. Those of you that know about endometriosis, has been battling with this condition, we would love to hear from you. It's we're here. We're here, guys. Just calling. She's right here. She's willing to answer your questions. Okay. Is there anything naturally in terms of diet or so that you would usually tell your patients to either lessen on or to watch out, especially when dealing with estrogen?
Yes. So in terms of estrogen, it also comes from the fat layer under your skin.
Yeah.
Therefore, definitely try to keep a low carb, low fat diet. It will help to reduce how much estrogen your body's producing. because you do tend to find patients who are obese producing more estrogen. They may not have, in particular, endometriosis, but
Mhm.
they will present with heavier cycles as well because you have more estrogen in your body. Your lining will respond to that estrogen, become a lot thicker than usual, and lead to very heavy or prolonged cycles.
Okay.
I did come across as well in my research increasing your long chain omega fatty acids in your diet. And you can get that from seafood. That actually is one of the things that helps to decrease the risk of endometriosis.
Okay, wonderful. All right. So definitely we want to add our omega-3s to our diet. And of
Mhm.
course, we know decreasing fats and also a low carb diet would definitely help lessen our estrogen levels. All right. So I think Dr. Harford, um, thank you so much for joining us. You did share a wealth of information with us on endometriosis. It is a topic that it's somewhat silent. Many people don't talk about it, but they do suffer from it because it's not well taught. It's not some many physicians may not. It's easily misdiagnosed as well.
Mhm.
Sometimes the presentation do look like okay. Chances are it could be maybe in terms of the clinical manifestation, it may
Mhm.
present as okay, chances are you may have a fibroid, but then when you do imaging, no fibroid is seen. All right.
Correct.
So I
Mhm.
guess then we would have to look into a different diagnosis, and that is where it is then later picked up. So endometriosis, a lot of young women will tell you that it's only after or believing chances that they could have this diagnosis, it then turned out that it was something else. Yeah, so endometriosis is something that a lot of young women will tell you that they have suffered with and still is battling with it. Yeah. So I guess that's most of the questions we had this evening. We is there are we still waiting? I guess there's someone else that wants to ask a question.
Sure.
Okay. All right. So we have another question for you.
Mhm.
The question goes, what about surgical treatment options?
Okay.
So
So
I go
for
ahead.
the lesions itself, you can actually enter the abdomen, whether it's open case or laparoscopy, which is just putting a camera at the belly button and other instruments in to work, and
Mhm.
you can burn these lesions off. Now, that's to remove the actual lesions that are there already. But
Okay.
any other surgical options that will reduce your menstrual cycle will, in fact, help with endometriosis.
Mhm.
And some of these include a less invasive surgical option, endometrial ablation. So, what
Okay.
that is, it's actually removing the lining of the uterus. So, if you don't have the endometrial cells on there, then there is nothing to respond to hormones and you don't have a period.
Mhm.
This includes going to the hospital, or some patients, it depends on where you practice, they may offer that in an office setting as well.
Mhm.
But something is placed inside of the uterus. It's shaped essentially like a triangle, so it comes in contact with the walls of your uterus at the top and on the sides,
Okay.
and an energy source is activated and it burns off or removes the lining of the uterus. So that's one less invasive surgical option you can use as well. And if a woman has completed childbearing,
Okay.
then hysterectomy, as well as removing the tubes and the ovary, depending on her age, is an excellent option to help with endometriosis and has been proven to decrease symptoms tremendously if they do choose to do that after they've completed childbearing. So
So
those are some of the surgical options.
okay. So in your opinion, would you say the ablation would be better than the total hysterectomy, or the total hysterectomy is better than the ablation?
Now, keep you have risk factors associated with major surgery. So not everybody's a candidate for major surgery.
Excellent.
So if a patient, based on their health conditions, also patients have the feeling or the idea or the thought that they'll be empty after removing a uterus. You have to
Mhm.
respect the patient's
Yes.
wishes and their
Yes.
concerns.
Yes. Mhm.
So if that is something they definitely don't want, meaning they do not want the uterus to be removed, that's an option for them. Now,
Mhm.
there's workup that has to be done to make sure the patient can safely undergo an endometrial ablation. The
Okay.
cavity has to be a normal shape, and
Mhm.
also the lining has to be checked to make sure there's no abnormal cells or no cancerous cells on the lining. So once that's completed, then they can undergo that surgery, and it's a faster recovery.
Okay.
You're not going to have any incisions on your abdomen. Everything is done from the vaginal approach, and it's a lot faster recovery for them.
Okay, great. All right, so we have another question. Um, what would you say that women who are on contraceptives are in a better place to where endometriosis is concerned? Okay, so let's take this question over. Would you say that women who are on contraceptives are in a better place where endometriosis is concerned? So I think I understand. So women who are on oral contraceptives, will they benefit being on that oral contraceptives having endometriosis?
Absolutely,
Hmm.
absolutely. Because it helps in several ways. Number one, it decreases the estrogen coming from the ovary, meaning what you produce yourself.
Yeah.
And number two, oral contraceptive pills are supposed to decrease how much bleeding you're having. And remember, heavier cycles, you have a higher risk of endometriosis. So if you decrease that, it should help as well.
Yes. Okay. So that is okay. Okay then. All right. I was just listening. I'm reading a comment from one of
Okay.
our viewers there. So
Okay.
something so to definitely I what we can definitely see that the total hysterectomy is what we would say is a major invasive surgery, right?
Correct.
Whereas the
Mhm.
endometrial ablation is mildly invasive,
Mhm.
and as you said, it's going through a port through the umbilical area, and it's actually getting into the uterus, and we're just scraping off that endometrial those area endometrial cells or tissue that are located. You said etopically, right?
Well, that's laparoscopy. With the endometrial ablation, we're actually going vaginally. So just imagine you're having a
Mhm.
pap smear
Okay.
and everything is done from the bottom. There's no incisions at all on your abdomen.
Mm. Mhm.
Everything is done through your cervix. So if you look at
Okay.
this picture that you have up there right now,
Mhm.
you
Mhm.
enter from the bottom and you go
Mhm.
straight through, and it actually is about the width of your pinky.
All right.
And it
Okay.
enters into that spot. A lever
Mhm.
is pulled,
Mhm.
and a little mesh opens up. That's the shape. It's a triangular mesh
Uh-huh.
that opens up, and it's in contact with the walls. The
Nice.
top, you
Mhm.
see, it kind of shaped like a triangle, right? You can see
Right.
that.
In the uterus,
So
yes.
that comes in contact with the lining and it burns it off.
Mhm.
So there's actually no cutting or anything involved.
Mhm.
This would not take care of any lesions that are already in your abdomen because we're not entering your abdomen from up
Mhm.
top. But what
Okay.
it will do is stop your cycles. And in so
Okay.
doing, it will help to decrease your risk of endometriosis. Now think
Mhm.
about patients who are not candidates for oral contraceptive pills.
Okay.
Patients who are smokers, who are 30 years and older, patients who have a higher risk of blood clots in their legs, patients who have migraines with aura, as simple as it might you might think,
Yeah.
headaches, and they
Mhm.
have like the flashing lights, the nausea, the vomiting associated with that. They are not candidates for any pills that contain estrogen. So
Yes.
not everybody is a candidate for medical options. So you do have to explore each option and individualize your care based on the patient's history and their presentation.
Okay. Wonderful, doctor. And what about the healing time, the recovery time for this procedure?
So with an endometrial ablation, I have had patients who went back to work within 2 days and others who would take their 2 weeks off, but anywhere from that range. And also in terms of recovery, I would tell the patients I've had some who had zero pain, no
Wow.
problems at all, and others who may have severe cramping after that procedure. And
Okay.
this, I just want people to kind of visualize. Imagine if you touch something hot,
Mm-hmm.
you a blister forms right on your skin,
Yeah.
that fluid.
Mm-hmm.
So when you burn that lining off, they're gonna have that liquid or brownish discharge, the charred tissue as well. So some patients may do fine with burn injuries, some may not.
Mm-hmm.
So it creates that pain or burning, and it also creates that fluid as well when you have that surgery done, that procedure done. So it depends on the patient, on their pain threshold, how quickly they will recover. But ideally, I would say 1 to 2 weeks after you should be off of work. I have patients who have gone back within 2 days.
Wow. That's
Yes.
awesome. Nice. So, what is the recurrent rate like in a surgical procedure like that
For heavy periods.
for the endometrial ablation?
Okay. So most patients, once it's successful, they
Mm-hmm.
can go up to 10 years without ever having a cycle.
Mm-hmm.
Now, others who it may not have worked, 100%, and it probably just burned partially, like partially removed the lining, their
Mm-hmm.
cycles may come back, but it's going to be a lot less than what they're used to. And
Okay.
I have had some, depending on what the patient situation is and their initial presentation for why we're doing the surgery, where it just does not work. And they may resume heavy cycles within 6 months to a year after having it. And then they would move on to a hysterectomy if that was the case.
Okay. All right. All right, Dr. Harford, thank you so much for
You are
answering
welcome.
all our questions. I know the endometrial ablation was very interesting for some of our viewers as pertaining to surgery and actual the invasive procedure. All right. So I think you had answered most of our questions for us. If there is any more viewers, we are waiting. We're going to give you at least a minute or two. All right. If you would like to ask Dr. Hafford any more questions, again, you can call in on our WhatsApp number on 403-1031. She is here, available and willing to answer you on the topic endometriosis. All right. So, Dr. Hoffa, again, we want to say thank you for sharing your expertise on this condition that somewhat may be uncommon to viewers and listeners, but it does exist. And it's something that is silent and a lot of women are experiencing, but they don't really speak much about it because it's not really common out there. Right. So, we're really happy to have you share your expertise with us as to what it is, its causes, some of the risk factors, and how we go about treating it. So we just want to thank you tonight for taking time out from your busy schedule to come on Heavenly Medicine and share with us. Right? It is a blessing having you, and we really do appreciate you. So I just want
Thank
to
you.
say thank you again. Blessings to you. And I know I always say hello to your kitties because I know how they are. And I know this is the hour there for family time. But we just want to say thanks again for taking the time out and sharing with us. Blessings to you and all our viewers and listeners. Again, you're listening to Heavenly Medicine. I am your host, Dr. Xenia Louison, and joining us once again is Dr. Janelle Halford. If there is any questions, we're still waiting. We give you up to a minute, so we have about 60 seconds. She's right here, so we're waiting a little bit. Okay, all right. So someone said that the answer you answered already. All right. So thank you guys. I always say at the end of the day, your health is your wealth. So it's a blessing to share with you. And we hope that this episode would have given you knowledge and some wisdom pertaining to this topic. So blessings again. Have a good night. And we wish you a blessed evening. Again, till next time. Blessings. All right. Goodbye. Take care.
You didn't come for the strong, you're here for the broken. This is my song of intercession, God. Only you know, only you know how it feels inside. This pain when you try to hide it, afraid to cry for help. You smile and drown it out. Only you know how it feels inside. To try and try and try and try and try and fail. Oh. Only you know why you say the clock and he's not at home. Out with his boys drinking, cause he knows when he goes home and opens that door, it's another night of fighting or silence. Oh, she's cutting up deep, and they just think that she's crazy, but you know better not. You know she's being touched in the wrong way. Oh, doctor, can you heal him? I pray, cause if you don't, he will not make it. Doctor, can you heal her? I pray, cause if you don't, she won't make it till the morning. Doctor, can you heal them? I pray, cause if you don't, they will not make it. Doctor, can you heal them? I pray, cause if you don't, they won't see the morning. Oh, 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 oh. Only you know how she feels inside. These feelings she's trying to hide, that's for another girl. It's not supposed to be. Only you know she prayed and prayed. How much she is afraid to get the help she needs, that your blood can set her free. Oh, only you know she's going to church but losing hope, cause he's tired of repenting for the same things over and over. It's almost over for him. Only you know I'm surrounded by broken people, and they need a hero cause they can't face what's wrong on the inside. Your boy's here to see them. Doctor, can you heal her? I pray, cause if you don't, she's not gonna make it. Doctor, can you heal her? I pray, yeah. Cause if you don't come, no. Doctor, can you heal them? I pray, yeah. Cause if you don't, no. Doctor, can you heal them? I pray. Cause if you don't, oh, they're not gonna make it. Tougher. Promise that you're the healer. Promise that you're the healer. By your stripes we are 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 healer. Can you heal it?
High on praise and exaltation, we are Hope 103.